All right, today's session is going to focus on value-based healthcare, and this has been the buzzword for probably the last decade. We have Datuk Professor Dr. Lui Lai Meng, whose CV is so long that the entire panel will be over by the time I finish. So please read it yourself. Okay, but suffice to say, she is the mother of pathology in Malaysia and probably the entire region. And with so many accolades, founding president of the College of Pathologists in the Academy of Medicine, Malaysia, and a former president of the World Association of Societies of Pathology and Lab Medicine. And clearly, Lai Meng is a deeply expert in basically laboratory medicine, and getting a right diagnosis is integral to the topic that we're going to talk about, value-based healthcare. But as Lai Meng is going to share later, getting the diagnosis right doesn't necessarily lead to action, right? And how do we close this last mile? We also have Professor Yot. Yot is a dear and old friend, whom in all our meetings can always be trusted to speak truth to power, no matter how painful and how politically sensitive it may be. So Yot, please don't let us down today, right? And Yot's primary role is in the MOPH in Thailand, where he runs HiTap, and he's also a visiting professor in the National University of Singapore at the Swee School of Public Health. And lastly, we have got Professor Nicholas Graves, who's a health economist at Duke and US Medical School. And Nicholas focuses on health econs, and he asked me to say that he particularly enjoys projects that reveal how health services can be improved at low cost or even with cost savings. So Nicholas is the finance ministry's favorite person because he says we can do more with less, right? And on that note, maybe let's start with you, really, Nicholas. What does value-based healthcare mean to you? And maybe since you've asked me to put this in your bio, could you share some examples of how, through the work that you've done or you've seen done, how are we getting more for less? Because it is very clear that today, even in the most conservative estimates, 30% of healthcare expenditure is wasteful or it's inefficient, right? And there's also the issue of fraud. And even in sophisticated markets like the US, the estimates range, but it can be as high as 10% Medicare, which is their coverage scheme for the seniors, to have up to 10% of fraud. And post-pandemic, most of our governments in ASEAN are fiscally very, very challenged. So while we may make light of doing more with less, the reality facing us moving forward is truly that we may not have a choice. And maybe, Nicholas, could you say more to that and how you think about value-based healthcare?
Yeah, thank you very much for this opportunity. So before I answer your question, I'll just say that.
Dan, I spoke too soon. Welcome back, Nicholas.
Sorry, did you hear that? What I just said, or should I start
No,
again?
I'm afraid we lost you almost from the start. Could you run again?
Yeah, sure. So thank you for having me today. Before I answer your question, I'll just say that data about the value of our healthcare is very useful, but it is not a panacea. It's not a golden bullet. So much as I think the work of health economists is important, almost more important is the work of implementation science, which is doing something with the data. So I've spent my career publishing papers about high value and low value care. And I think I initially expected the whole world just to swoon and just adopt what the paper suggested, but it doesn't work like that. It's much more complicated. So I'll sort of preface this discussion by saying, once we've got the evidence, you need to know what to do with it in terms of engaging with policymakers, understanding the context, changing clinicians' preferences, working with patient groups. So it's a wicked, complicated problem. So that's just an intro. But to answer your question, I am passionate about value-based care and about getting a good return from our scarce resources. And as an economist, we think about value in a very specific way. We think about improving the value of the health outcomes for patients per dollar spent. So we have one outcome measure, which is called the quality adjusted life year, which is if you like, a consistent measure of health benefits. And that measure can be used to judge how much health benefit we get from any program, be it primary prevention, diagnostics, complex surgery, whatever it may be. So, this is very much fitting within a cost effectiveness framework, because this allows us to choose the programs that deliver the most health per dollar spent. So the value-based healthcare program is less explicit and less disciplined, because in value-based healthcare, you can pick any measure of improvement you want. You can say, how much money do we have to spend to get patient satisfaction improved, or reduce mortality, or improve symptoms? And this information, although it's useful, it doesn't help us allocate scarce resources amongst competing alternatives. So, I am a fan of value-based healthcare. I think it's important, but I think the really important framework is to think about cost effectiveness, because that allows us to find ways of improving the amount of health benefits we get from all the different things we can use our scarce resources on in the healthcare sector. So that's my opening salvo, if you like. Thank you.
Thank you very much, Nicholas. And I see Lai Ming itching to say something. So Lai Ming, over to you, please.
Yeah, I think the topic here is really on value based. I'm really very, very pleased that there is this session, because there is always in so many forums the discussion on cost and cost benefit. But value, I think, is very different from cost. I mean, there are some similarities. Very often we ask people what's the value of something, they straight away say, well, if you can do it cheaper, then you got more value for money. But I would try to answer from the laboratory side, because that's where my experience is. Very often, the value concept does not filter through in healthcare. And in the laboratory side, we always ask, if you want to perform a test, introduce a test, the question should be, how does it translate to better outcomes for the patient? Not just a matter of, will it bring down the cost of testing? And in my 40 years of teaching medical students as well as trainee pathologists, very often I ask my trainee, you want to do a particular accessory to the test, like in histopathology, you want to do additional stains, and each stains costs 140 ringgit to do. Do you need to do so many accessories to reach the diagnosis if you're already more or less 100% confident that what you're seeing under the microscope is a breast cancer, for example? But you want to do more and more tests to just to confirm and confirm again. I mean, how many times you want to confirm? I mean, so very often the concept of value does not filter through. And similarly, when new services are developed in a hospital setting or patient care setting, very often the understanding of the various players in the introduction or deployment of a new system, whether it be digital pathology or anything, but of course digital is what we are talking about today, and it applies equally to digital.
Can I ask you, because you are one of the rare breeds of people who are medically trained and also have very deep expertise in health economics, right? Where do you see this conundrum of value versus cost, as what Lai Ming had shared, and and how do you bridge this challenge that Nicholas had articulated around implementation? Right. Yachts, over to you.
Okay, so 2 points. The first is about the cost and the values. I think it is something that I it's very important when we are talking about value-based healthcare. You need to think about, I mean, what are values and whose value. Um, and I can think based on my personal experience working for a health technology assessment agency, which is an organization that are assessing values of healthcare and health technologies. However, we are not the one who make a decisions. in Thailand, we are the one who assessing and inform policymakers, health minister, and the committees to make a decisions. And we always discuss. I mean, when we are assessing values, is which value and whose values. And I learned that sometimes the value is not only about cost, especially in healthcare. Sometimes its value is not about value for money too. It's about values of, I mean, making more health equitable system. I mean, more equitable health system, etc. So we are not going to let vulnerables behind, something like that. And also, I learned sometimes is that the value is not only the outcome, but it's about the process that we are valued as well. The process of providing care, the process of making healthcare decisions, whether the way that we make clinicians making decisions whether to treat or not to treat is transparent, is participatory enough, is evidence informed, etc. So this kind of thing, I think, is we can count as a value too. However, having said that, I think it is being another challenge. I think Peter Drucker, I mean the American thinkers, have said before that you cannot if you cannot measure it, you cannot improve it. So in this case, I mean, sometimes the values given to healthcare is very difficult to be measurable. But let believe that health economists, including Nick and myself, if we trying to measure everything that is even people think is unmeasurable. So this is something that I think um, we can discuss, and we need to think about that we are introducing new terms and new concept. As Nick already said, one thing is about quality adjusted life year, healthy life year, something like that. And it is the one of the things that I think is more and more that healthcare around the world are accepting. This is one of perhaps representing the values of healthcare. But as informed, it's not everything. Over to you.
Okay. Uh, Thanks, Yot. I want to shift gears a little to talk about digital health interventions. And one of the common bugbears amongst the digital health community is that health economists compare a digital health intervention against some romanticized, idealized vision of what is supposed to happen versus what actually happens. Many of us in the room will be familiar with the PICO format, where we look at the population, the intervention, what we compare against, and the outcome. And often, if we only confine ourselves to the published data, the digital health intervention will be inappropriately compared to a best in class, which doesn't exist in the real world. And this morning, we had discussed about how digital health is intended to expand scalability as well as reach. So these are populations that traditionally may not be reached. From a methodology point of view, maybe I could ask the two gentlemen, Nick and Yot, how do you think about applying the research methodologies, the PICO frameworks to digital health interventions when the comparator may not be evident, or what's in the academic literature may not be that suitable? Nick,
I'm happy
please.
to kick off. Yeah. So choosing the right comparator is essential for a useful piece of research. And I think most health economists would spend a lot of time trying to carefully think through what the appropriate existing practice comparator looks like. If we turn to the literature, we're likely to find randomized controlled trials, which don't often represent the real world because they're set up in somewhat controlled, protocol-driven experimental conditions. So I agree that randomized controlled trials, very tight designs, give us one measure of clinical effectiveness, but they might not represent the real world. We all know the rough and tumble of health services is nothing like a randomized controlled trial. So I'm wary of using sort of RCT data. Well, it plays a role, but I would rather get involved in real world registry data, electronic patient records, and try and understand, with some uncertainty included, what the outcomes are in the day-to-day of health services. So I'm less worried about the tightness of the study design, and I'm more interested in the generalizability from, we can achieve from the data we have. The key to doing this well is understanding big sources of bias in your data and then trying to control for them statistically, which can be done. And also making sure that you use real world evidence for cost outcomes, effectiveness outcomes, health benefits. And so this is operationalized in a modeling framework. And I do a lot of modeling research because we can pull in real world data. We can describe how the world functions at the moment under existing practice. And we can then use, with uncertainty again, some estimates of how we think we're going to change the world by bringing in a tech-based or an app-based application. So it's all about understanding the bias, including the uncertainty. And all we have to do at the end of the day is inform a decision. We don't have to be very precise. As long as we make the right decision, either adopt or reject, then we've done our job. So it's not about hitting a p-value of 0.5 or meeting some prior hypothesis. We're not interested in being very precise. We're interested in choosing the right option, which is easier to do. We need less data, and we can deal with uncertain data if we set ourselves the goal of making the right decision.
Yeah. Thanks, Nick. Before I turn to Yot, can I push you a little bit more in that since the 1990s, when we have educated generations of medical students on evidence-based medicine and how level 1 evidence is, you've got to have meta-analysis, systematic reviews, RCTs, and then we tell them that in the messy digital health world, oh, no, the RCT is just one data point, but we really want to look at electronic medical records and all. What's the sort of reaction that you get from the clinicians that all of us have thought to practice evidence-based medicine?
Yeah, so I think the whole scientific community, including educators, journal editors, peer reviewers, have tied themselves in.
I did speak too soon. I'm so sad. Okay.
Sorry, have I gone? Have I gone? Am I?
We lost you a little bit when you were speaking about educators and journal editors. Could you go back to that point? Thanks.
Yeah. So I think that the whole community has tied itself into knots with this obsession with precision, and it's an unhealthy obsession. And I would go so far as to say that they haven't fully appreciated what their task is. Their task is to understand and choose the best services. It's not to measure things with precision. So I think that whole effort, although valuable, and it sets a culture of understanding data, understanding research methods, making good decisions. I like the culture, but to operationalize it, you don't need to get hung up on precision, on p-values, on very, very tight designs. That I think is a red herring. The world is messy. There's lots of data about the world. We've even got expert opinion that we can bring into this. And as I said before, all we have to do is pick the right option. And so it's the probability or the certainty we have around our decision to pick an option, which is our key statistic.
Yeah. Thanks, Nick. And that's really making the right decision. And to all of us purists, it's really take a chill pill. The world is messy. Right? Yes.
And sorry, I don't want to dominate, but I'll just finish up with, if we complete our analysis and we've got a lot of uncertainty, so it's too messy and we feel uncomfortable making a decision, then we're still in a very strong position, because we can then ask ourselves, where's the uncertainty coming from? And once we understand, say the uncertainty is coming from the epidemiology of long-term adverse events, then we know where to do our next piece of research. So we do a longitudinal study of long-term adverse events. 5 years later, we have the information we need. We can go back to our decision problem, and the decision will become a lot clearer. So even our research effort is then informed by this imperative to make good decisions. So I'm fine with uncertainty. I'm fine with messy, because it tells us what we need to learn about and what we need to study next.
Thanks, Nick. Yot?
Yeah, I just want to, for sure, you shouldn't allow me to repeat an excellent response from Nick, but I just want to respond in another angle. I mean, as a researchers, HTA agency practitioner, something like that. You just imagine my job is assessing the values of technologies. And for sure, there will be two types of technologies waiting for assessments. One is the technology with good values, another one is with poor values. And then another thing is that I need to tell my government about whether they should adopt or support or implement those technologies. So there will be two type of decisions. If they are not taking what Nick said, that you can wait. But it's sometimes if you waiting not making an implementation, people perceive that the government say no. So there will be yes and no. You think about 2x2 table. So what we want to see the most is that the government or the policymakers say yes to good value technologies and then say no to poor value technologies.
Yeah.
However, sometimes we make it less than perfect work, and we come up with, the government say yes to poor value technologies, and then the government say no to good technologies. On the last one, when they say no to good technologies, I'm not so much worried because companies, patients, clinicians will all say to us that this is not you make not make the right things. You have some problem in your evaluation. The government have problem in their decision, etc. So people will voice to get the good technologies, good value technology to be funded by the government anyway at the end. However, one thing is that when we decided to fund or to support poor value technologies, no one will voice because no one have a real pain because the government say pay the money knowing or not knowing this is poor value technology. The companies are happy because they can sell this technology. Why they need to be worried? But the patient, the people, sometimes they use it without knowing whether it's beneficial to them. And this is a big problem for values based healthcare because you are keeping paying and implementing and using low value technologies. And that's why I think one of the terms that Nick's saying about the low value healthcare, it should be mentioned when we are talking about value based healthcare. And I would say, I give you my last point is that when you asking whether PICO or whether the approach we use for general technology can be applied for digital technologies, I would say yes. And is similar to even personalized medicine that we are evaluating. I don't think they are different. However, because of what you say about the low monetizations of this technology, sometimes it makes us very difficult. To say this is not good value technology. My good example is that just last month, we finished one randomized control trial to this is the research that requested by the Ministry of Public Health in Thailand because now everyone wears smartwatch and you perceive this is something make you smarter, make you healthier, and then the government have an idea whether we should give this smartwatch for example for NCD people, for people with sedentary behavior, and the company keep promoting if you're using it you can improve 20% of your physical activity, etc. So we do RCT in Thailand and we end up showing that there is no significant difference in anything. But people keep, not believing because they feel romantizations of these technologies. So this is something that perhaps my last message is that yes, we need to be clear and we need to be neutral when assessing and when making a decision about value of technologies. Over to you.
Yeah. Thanks, Yot. And yes, gentlemen, the world is messy. The data can be ambiguous. And what Nick says very nicely is that we don't need to find precision. What we want is to make good decisions about options A, options B. And maybe, Laimi, can I turn to you to react to this and also share in the decades you've been working with policymakers? Can you build on Yot's point where he says that he thinks policymakers don't fully understand?
Yeah, I think before I respond to that, I'd just like to perhaps, in a way, step on dangerous ground, but comment on what Nicholas have mentioned. Of course, evidence-based, I still believe is extremely important, but having to say whether PICO is better than RCT or whatever, I think is an argument that's not necessary. Because in academia, we want to implement or we want to mold young minds to understand science-based and evidence-based in how we look at our patients, how we look at platforms we have, ways to understand things. But what is more important is to have the balance to choose what applies to what situation. And in patient care, and certainly even from the laboratory point of view, the best technology, according to a published data, may still not be the most appropriate for your patient, depending on what other comorbidities he has. So the idea is to have the balance and be patient-centric. Now, when it comes to introducing new ideas and new technologies into the healthcare services, we, as medical people, we need to talk to policymakers. And that is basically the question you wanted to pose to me. And in all my years of dealing with policymakers, I've seen that where we fail is not, I mean, it's not always on the part of policymakers not willing to listen to us. It is actually on the part of us not willing to speak properly to them. We submit a paper full of scientific jargon and full of p-values and all kinds of calculations, and you expect a busy policymaker from a completely different background to look at that and reach your scientific conclusion that this is what should be implemented. I think that is, if you look at it from an understanding point of view, more or less insane. I mean, do you talk to your patients like that? So why talk to policymakers like that? I think it is important for medical people now, scientific people, to learn to be in the real world and to speak to policymakers, whether it be at your hospital level or higher up or at national level, in a language that is understandable, and to be able to put forward again the value proposition. Sometimes the argument is not always cost. Sometimes argument is not always, this is new. That country has it. In Malaysia, we say, oh, Singapore has it, so we must also have it. I mean, that's not the argument that should be used. It should be, in our context, we have a need. We think that this can address the need. Explain why you think it can address the need and how it will, it is better than what we already have. And is it, of course, you still have to bring in the economics. Is it implementable? Is it feasible? But get down to basic, understandable language. And I find that many of the times when we do succeed in getting something done, it is because we take the trouble to explain things in understandable language. That's really all there is to it. I think people are basically reasonable. If you will speak reason. Thank you.
And I think that's a very valid point, that there are no policymakers who wake up and ask, how many people do I want to kill today? Right? Everyone's really, Subra, don't look so shocked. Right? We're all trying to do a good job with our limited resources, with our limited understanding. And I'm really glad that Rifat has come in to join us. And I'm going to ask you in a short while, Rifat, about the issue of context and about digital health interventions. But I want to circle back to Nick very quickly to look at implementation science and how to address Liming's challenge of talking to policymakers. Since, Nick, you enjoy working with policymakers, what are some of the tips that you have learned over the years in helping them to understand? Because as really Liming correctly points out, it takes two hands to clap, right? There's the policymaker hand that strives to understand. How do we, on the other side, make it easy for them to understand?
Yeah, thank you. So, I really enjoyed hearing Lai Ming's comments. I thought they were super. And particularly the point about providing information that policymakers can act on, because we all suffer from jargon. We publish in paper.
Don't worry, he will be back. 3, 2, 1, 0.5. All right, here we go.
How much did you get? Did you get any of that?
We missed most of it, I'm afraid.
All right, I'll be brief. I'll recap. So I enjoyed Lai Ming's comments, particularly the point about providing information that policymakers can understand and can use. So I'm against publishing obscure papers in obscure journals that no one can benefit from. So generating simple statistics about the probability that adopting something will increase the amount of health benefits we get from a fixed budget, I think is a message that people can understand. But that, as I said before, is only one part of the story. All decisions are multi-criteria, and demonstrating cost effectiveness is important, but not everything. We also need to think about other preferences that decision makers have. They may have preferences for equity and fairness, which are very important preferences. They may have political preferences. They've got to get elected next time round. So they might do things which are not cost effective, but popular. And so, politics plays a role in this as well. There may be patient advocacy groups who are very powerful. And so they have to listen to the voices of the patients, which again is important, but it might be against the aim of cost effectiveness. So we're always trading off many, many factors. And the art of a good implementation is to understand which buttons need to be pressed for policymakers to proceed. And it may be a second best outcome. At times we may not get efficient outcomes. But if you want something implemented, maybe efficiency isn't the only consideration. So again, the world is messy, the world is complicated, many, many criteria to sort of balance and juggle.
Thank you very much, Nick, and welcome, Rifat. It's great to have you join us. I think it's a rather awkward time zone for you, so thank you very much for really being with us. We were discussing digital health interventions in the world of value-based healthcare and some of the difficulties in finding what are the right comparators to benchmark digital health interventions against. And we are just going down the path of wondering aloud about the context. And I think Nick gave a litany of the political, the socio-economic factors that are very specific to really communities. And maybe Nick, since I'm the moderator, let me call out also that many politicians are worried about being accused of not being evidence-based and being corrupt in some way, taking a bribe if they make decisions based on subjective measures that cannot be easily quantified. And maybe, Rifat, given that you've worked in so many countries around the world, and you're based in Boston, how do you see digital health interventions developed in the so-called Western world or the highly developed world? How then do we bring it into low and middle income countries, bearing in mind that the context are very different, because ultimately what we still want is to maximize the value for our societies. And over to you, Rifat. Thank you.
Yes, thank you, Jeremy, and apologies. I had some technical difficulties joining. There's no doubt that digital health technologies will transform health systems, and that is much needed, because health systems are, if we're honest with each other, health systems have been underperforming for years. If you look at management of common conditions, control levels are extremely poor in most countries. The response to COVID-19 was also suboptimal in many settings, not least in the US. So there's no doubt that digital health will be really the ingredient that will help this transformation from health systems that were designed for past problems to systems that are fit for purpose, with aging populations, chronic disease, and multimorbidity. Now, having said that, it's very important to have real-world evidence and data with real-time analytics, because the field of digital health is moving very, very fast. In the US, for example, digital health applications are being used regularly, and there are many many innovations that are coming through aimed at improving efficiency of the care delivered, improving effectiveness of the care delivered, improving outcomes, ensuring that guidelines are applied appropriately, ensuring more equitable care. Again, there's a whole host of interventions, and we cannot apply the traditional rules of doing RCTs on everything, because this would take years. And by the time we finished an RCT, randomized control trial, the technology would have changed. So use of real world evidence and use of new analytic techniques, analytic methods will generate evidence to tell us if an intervention is working optimally or suboptimally, and iteratively refine what works in different settings. So I think we need to change our mindset in the way we assess suitability of a technology, in the way they improve outcomes and in the way they improve efficiency.
Yeah, thank you very much, Rifat. And I think you are absolutely right that that because of the speed of really refinements and enhancements in digital health interventions, that the traditional models of cost effectiveness analysis break down, right? As you correctly pointed out, by the time we as the technical folks have finished reviewing version 1, the developers have moved on to version 5. So this notion of real world evidence becomes absolutely critical. And we were discussing over the last day and a half that if nobody gave the iPhone or the smartphone version 1.0, the brick-like device, a chance we would not have the super computers in our hands today. So technology has a certain maturation curve. In a lot of innovations, particularly digital ones, version 1, version 2 may not be terribly good. But if they are still born at version 1, version 2, the world will never benefit from the version 5s and version 6s. We have got about 10 minutes left. I want to open this to the audience that is in the room. And I also want to challenge our really technology partners here in Brunei, IVIT, to address this question about context. We have heard earlier today the phenomenal work Brunei has been doing, supported by its technology partner, AVIT. But as AVIT thinks about scaling beyond Brunei, how do you think about making sure that the technology is suitable for context? And I will ask Tian to either respond or find someone to respond. But in the meantime, are there any questions from the audience? We have a very, very illustrious panel full of experience. One chance to ask them politically incorrect or very correct questions. Yes, please. Now we need the runner, like a tennis tournament, to run with the microphone. Over there, over there. Okay, we will take 2 questions before I'll ask Ivit to really talk about this question about context. Please.
Okay. Hi, good afternoon. I have a question. I'm Yvonne from Avid Technology. So I'd like to ask, what is the bulk of costs incurred in healthcare, and how can we prevent fraud with the use of technology? Thank you.
Thank you. So the question is really around the cost of healthcare, the cost of health technology, right? And how do we go about? That's why we have wonderful companies like IVIT that will invest first and then recover the money later. But I jest. Would the panel have any response to this? Because in the traditional tech world, there's a lot of investment upfront, which is then recovered as the technology scales up. And one of the difficulties personally I have seen in the healthcare world is because it's so context specific, as Nick had shared, that the scalability is not straightforward. You build a WhatsApp and you can scale it across multiple countries much more easily, right? But in digital health interventions, particularly those that are community-based, there's a good amount of adaptation and localization needed, which in turn incurs cost. So what should be the right I hate to say this, almost business model to enable digital health interventions to flourish. Anyone wants to
May I
take this?
comment on the cost?
Please, Rifat.
Well, first of all, I think there's a myth regarding cost of technology. If you look at OECD data, the data from Organization for Economic Countries of Economic Cooperation and Development, cost for health technologies, medicines, consumables is around 18 to 25% of total cost. And this is where all the innovation is happening. The major cost for health systems is the rest of the system, where innovation is not happening. Delivery models have not changed very much, and we're still using structures that go back centuries. So that's first. Secondly, we shouldn't be just looking at cost, we should be looking at the returns. And they're very substantial health, economic, and societal returns of adopting new technologies. So the analysis should include looking at short and long-term benefits. Third, in relation to the adaptation, yes, with any innovation, there will be a core that is replicable, that can be scaled up in any setting. And of course, there will be some adaptation in each setting, depending on the difference of context. But that is not a hindrance or a barrier to rapid scale-up. So I think we need to have a fresh look at and think differently in relation to health technologies, not just think about cost, but think of this as an investment with a return, which is actually very substantial.
Yeah. Thank you, Rifat. And I like your point about the core being central and common across. I know this is a public health conference, but I'm reminded of McDonald's in this part of the world, where Singapore may have a rendang burger, Malaysia may have something else. There will be rice in Thailand, and really so on. But would the other panelists like to comment?
Yeah, maybe I do.
York first, and then Lai Meng.
Yeah.
Please, York, go
So
ahead.
I talk about two concepts in economics that I think is applied to every technologies, but it's more prominent in digital technology, is the concept of economy of scale and economy of scope. I think because of a lot of costs in digital health are sunk costs, so it means it's an upfront cost, it's a cost of infrastructure, etc. So it will be very marginal cost to scaling up and to so this is something that normally in health technology assessment or in others value-based healthcare we are not talking too much. We look only the present cost. We not projected for futures, the cost of the futures, and that I think we need to think more. Trying to think once digital technology is being used at scale. I mean the cost will be down very quickly, and not only on the same things, but some infrastructure can be used and applied for other. So you get both economy of scale and economy of scope. And this is something that when we are evaluating or we are thinking about digital technology, this is something that economists should do more.
Thanks, York. And Lai Meng?
Yeah, I mean, I would like to build up on the point brought up by Rifat, that perhaps we should not just be looking at the cost that you put into developing an application,
Yes.
or a technology, but the returns. And to look at returns, actually, you have to think in terms of how applicable is the technology you're introducing. As a point in hand, let's say, again, I'm speaking from the laboratory point of view, since my experience is there. We're looking at using artificial intelligence on digital images of cells that could help to make diagnosis.
Yes.
All right, say cancer diagnosis or screening, and of pap smears or screening of whatever. There is none at the moment that is really applied yet, but the cost to develop that may be quite high, and a lot of effort, and a lot of labor, a lot of a very big project in a sense. But you look at the returns in terms of when it works, there'll be so many centers,
Yeah.
regional, worldwide, that can adopt this. I mean, it's just like how mobile phones have gone. At the beginning, when there were none, it was unimaginable, but now it's so global. So it is the scale up, the returns that's going to matter the most. You have to look a bit broader vision. And in that, do not forget again the value proposition, because it doesn't help to develop a technology and then try to look for an application, an applicability. I think it is important to look at what is the need. Is there a big market need for something? And then develop the technology to address that need. So in the diagnostic area that I'm speaking from, we need something that's precise, that can be efficient, that can save time and labor in making a diagnosis more quick, for example, in cancer,
Yes.
and develop the technology to address that, that can be better than what we have right now.
Okay.
And I think in terms of value and returns. Thank you.
Thanks. And in the startup world, we call this a solution looking for a problem versus a problem looking for a solution. And I think in the healthcare world, we always have to start with the use case, right? And far too common, particularly in the Singapore experience, we really started out often with very clever engineering solutions, trying to fit them into the health system rather than the other way around. I'm afraid we're running out of time, but I would love to hear an industry practitioner view. Is there anyone from our technology partner who can say something about the contextualization?
Hi, Prof.
Please. And can you introduce yourself also?
So I'm Hong Shen. I head population health in AVID. I think if I understand your question correctly,
It is about contextualization across different populations, different communities.
Absolutely.
And particularly for AVID, how are you thinking about it?
Yeah. So AVID, we have a global business, and we are in a very tough industry, which is healthcare, where a lot of things needs to be localized and needs to be contextualized to the local market that we are in. So I think I'll attempt to answer this question in two parts, right? So one, on the technological front, while all our technological partners or all our partners want our technology to be scalable, there are still unique features within the country that will make us very difficult to scale, right? So an example is that while we deploy a solution in the US using the Amazon Web Server, the commercial cloud environment, and we go to the Singapore environment, right? And the ministry wants us to deploy this in the same AWS environment, but now it's a commercial cloud that's carved out for the ministry specifically. So now it's the H cloud, right? So while both are on Amazon, both are very difficult to deploy, and that makes the technology scalability very difficult. And without understanding that, then we'll risk going into the project saying that, yeah, it's a copy and paste, right?
Yes.
So
Okay.
important to help them understand that while we are in the same environment, it's difficult. Then we go into the operations part of healthcare, right? So delivery of care is very different in many parts of the world. A way that we treat diabetes, while the framework might be the same, in the US, it's very different from where we are in Brunei, where we are in Singapore. So while the framework can be applied throughout all the businesses that we are in, it's important that we have local presence as well, which is why we have such a big team in Brunei to make sure that we get the localization correct. And I think as a company, we subscribe to that ethos, and we subscribe to that methodology of having boots on the ground, understanding what actually is the problem, and then try to solve it from there. Yep. So I hope that answers your question.
And thank you very much, Hong Shen. Given that we're really short of time, I want to go around to all the panelists to have a concluding one, two liner. And let's start with Lai Ming, and then we'll go to Nick, Yot, and then Rifat, because you joined the party late. So I'll give you a little bit more time. Yeah. Please, Lai
Well,
Ming.
I won't give a sort of technical kind of concluding remarks, but because I do dabble a bit in poetry, I hope you will allow me to
Please,
read
please.
a poem.
Please.
And that's why I have these notes here in front of me, because I don't want to misread this poem from T.S. Eliot, which I think applies very well to value. And I think we have talked so much about technology and about precision and so on, all of which have their place. But we're talking about value today. And it says, where is the life we have lost in living? So in living, don't lose your life.
Yeah.
Where is the wisdom we have lost in knowledge? So in our pursuit of knowledge, have we lost wisdom? Where is the knowledge we have lost in information? And we are so engrossed with information, but have we gained any knowledge? I won't take up too much time, but I think this applies to many aspects of our life. It applies to technology. It certainly applies to digital healthcare and to artificial intelligence. I'll leave it to my other panel members to put in the more technical conclusions. Thank you.
Thank you so much, Simon. And isn't it wonderful that we have poetry in a digital public health conference? All right, Nick, over to you, please.
Well, that's a tough act to follow. I'm not going to be poetic at all, I'm afraid. But
She's got T.S. Eliot. Who do you have in your corner?
Nothing so nice. So my take on this is that we do many things in healthcare which do no good or even harm people, and we use a lot of money, a lot of scarce resources doing those things. So they're never a good option. So one thing we can do is find those, and there's plenty of them out there. There's also a lot of things we do in healthcare that can save more than they cost to implement and also deliver gains to health. So, it's almost unethical not to choose those programs. So this is the easy stuff. Where the difficult stuff lies is where we have to spend extra resources to get extra health benefits. And here we're trading cost for health benefit. So we have to draw a line in the sand and say, how much are we willing to spend to get extra units of health benefit? And once we know that line, we can then judge new programs, new interventions against that line. So I'd say that those are the broad ways we can approach a health system. And just doing the first two of those, you could spend a whole career looking for stuff that harms people and costs money, and stuff that isn't implemented that helps people and saves more than it costs. So, that there's plenty of opportunity to make really important change.
Thank you, Nick. Yot?
I think maybe I just want to say that when I heard people talking or pushing for values-based healthcare, people always look at particular interventions and say it is a good intervention to make a good values in healthcare. But rarely people talking about value-based healthcare system. I mean, we need to look as a whole, not look as individual patients or individual interventions. And that is, I think, the thing that we need to think. If you want to look at the value-based healthcare system, then you cannot avoid trying to tracking the low values healthcare that we are keep providing. I would say a lot. I cannot name, but in the past I worked with the Thai and Indonesian government trying to stop doing diabetic screening for people just 15 or 14 years old, something like this. I think it is something that we need to think together over.
Right. Thank you, Yot. And Rifat, over to you for the last word.
Thank you. And I will not attempt at poetry, but offer three final thoughts. The first is we need to transition from technology or point solutions, episodic care, to longer-term solutions. So technology needs to be wrapped around a care process. Technology needs to be an enabler. And I think that's a very important message to the industry to think about what they're offering. Secondly, very important to think not just about value for money, but also value for many. We need to ensure that innovations are available at scale. And I think Yot's point regarding scale is very important, because with many new technologies, especially digital technologies, the marginal cost of scale up is actually very, very low. So the larger availability of solutions would mean lower average cost over time and larger benefits. So we need to think of this dynamic very carefully. And the third important point is we shouldn't just think about getting value from an episode of care. We need to think about getting value from the health system as a whole. Hence the need for transitioning from providing technologies, to providing more complex context-specific solutions to transform health systems in order to achieve improvements in health, as well as large economic benefits and societal benefits through health system transformation.
Yeah. Thank you so much, Rifat. And that really leads me just to conclude that in today's world where we're so fiscally challenged, value has to be a way of life for all of us in everything we do. Digital health technologies offer an opportunity to be game changing, but we have to do it well. And as Rifat eloquently says, the technology has to be in service of the health system. We have to think of how to create value, not just at the level of the individual intervention, but at the level of the health system. And every health system is unique, very contextual. And as our friend Hong Shen who is from our technology partner, Avid, mentioned, we not only have to think about the contextualization or the adaptation from the technological, but also the operational as well as the cultural points of view. Nick and Yot have both shared that new methods will need to be found to enable us to fully benefit from all the potential that digital health offers. And while I cannot quote T.S. Eliot, can I borrow from Yot's homeland, Thailand, and end by quoting a famous saying from Prince Mahidol of Songkhla, Thailand, where he describes that true success is not in the learning, but in its application to the benefit of mankind. And that's what digital health, that's what technology has to be all about. So thank you, everybody.